So I'm Rachel Davis. I'm so glad to have you guys here today and happy that you are joining us. I'm going to be talking about surgical education for people at all kind of segments of their training. And I think that it's an important topic, and we're even just now realizing in the past several years how vital it is to have dedicated training for this kind of work. So I have to say I have funding from these foundations. I don't know that it influences anything that I say, but it's the case. The points that I'll be hitting on are that we need surgical training for all career stages. I'll be talking about our global surgery program at Baylor, and then also the tropical surgery obstetrics and gynecology course that Dr. Belfort mentioned earlier. And then just a few tips for building your own surgical education program at your home institution. So if you're visiting from another state or another city and you don't have a global surgery educational program, you can develop one at any stage in your career. And it's good to have kind of an idea of where to start. And if you ever need help with that, please just let me know. There's this idea, I think, that has been very pervasive in global health, that if people don't have any medical care and people are dying, it's better to go and do something because something is better than nothing. And I think that this is really problematic in a lot of ways. It is true that in many cases something can be better than nothing, but as physicians, I think that it's important that we not just strive to be doing some kind of medical care, but that we be striving to do the best kind of medical care. And in other specialties, in surgery, you would never, send a vascular surgeon out and just say, oh, well, some kind of aneurysm repair is better than no aneurysm repair. You would train them to be skilled for their purpose. And I think we need to start considering that for global surgery as well. So what does that mean to be excellent in a resource-limited setting? You have to have the stuff, you have to have the people to be doing it, and you have to have expertise. And so in this talk, I'm not really talking about local surgeons. It's more geared toward American or high-income country surgeons who are going to be doing surgery in a low-resource setting. This fantastic article came out last August, and I really love it. I think it's really well done. So kudos to Yihan Lin. But one thing that it really showed us is that no, American surgery residents are not prepared for humanitarian deployment, not even a little bit. When you think about the way that we're trained actually in these topics. So a lot of things that are useful to global surgery have been kind of removed from our education. So even at Baylor, we don't necessarily do burns anymore. We definitely don't do anything involving the uterus. If there's a kidney, you generally will give that to urology. So we become really, really siloed in our education. And what that means is that we make really fantastic specialists, but that we may not be trained to be in a setting where we're the only surgeon. And so if you talk to people that are working in these settings, they'll be from the most incredible medical center in the world. I mean, Houston, you graduate, you think, oh, I'm from the biggest medical center in the world. Surely I should be ready to take on anything. And then the second somebody comes in with an open fracture or postpartum hemorrhage, you're like, oh, maybe not. Maybe I missed some things in my education. And so people just anecdotally will say, I was not prepared for these things. I needed to know how to do a hysterectomy or, how to do external fixation of a fracture. And so anecdotally, that's what they were saying. And now we actually have data to say what things do we need to be focusing on as global surgeons. And so this is taken from the 44 essential surgeries list from the DCP3 Volume 1 Essential Surgery, which is a fantastic resource if you haven't seen it before. And so this actually gives us a good overview of what sorts of things are not only just important and useful in these settings, but are financially worth doing and worth investing in. So the yellow, in evaluating this list, the yellow things are maybe still probably going to be limited to specialists, but everything in the white, you'll, as a surgeon in another context, you'll probably end up seeing or having to manage these things at some point when you're operating. So knowing these things anecdotally, even before they were available, before 2015 and 2017, training programs saw that this was a problem. And so they thought, how do we address this? And the way that it's been addressed in the past has really been along two pathways. So the first pathway was academic. So if we want to be a global surgeon, we need to go abroad and we need to do research. And if we research everything, then we'll know how to do the things the best way. And that is definitely important. And then the other way that has been addressed is, well, I don't really care about research, but I need to know practical skills. So you will see this sometimes with rural surgery training programs. And so they have many, many hands-on skills opportunities. They might have a more diverse training program than we do in maybe a non-rural focused training program. And so maybe they do learn C-sections and hysterectomies and fracture management, but it might not be to prepare them for global practice. It might just be skills training for a rural setting. But when you think about academic global surgery, we actually need all of these components. We need to know how to do these tasks, but we also need to know how to evaluate whether or not they're useful in certain settings or if there's a better way to manage them. So we have to have a very wide set of tools to be an academic global surgeon. So in 2014, we were trying to develop a program to train academic global surgeons. And this is what we came up with when we thought, what does that mean? What do you need to train someone in to be an academic global surgeon? We decided that they need to have some international experience because it's useful to know the context. So also rural experience is important. You do see a much more broad segment of general surgery than you would in a city with lots of resources. Skills training, so other specialties, it's important to study those as well. And then research, you have to be able to evaluate what you're doing. You have to understand the context. At our institution, the way that our residency program is set up is we have 8 residents annually. And of those, 4 match into a 5-year traditional pathway and 4 match into a 7-year pathway, which is an academic pathway that includes 2 years of research positioned after PGY 2. And when we were developing this framework, we actually took those 2 research years and we converted them into global surgery years for 1 position annually. And our goal, so starting this coming year, we'll actually split those 2 years. So it will go PGY 1, 2, then a global surgery year, 3, 4, 5, then second global surgery year that functions almost as a junior faculty year. And the point of doing that is that if you learn how to do a hysterectomy, but it's been 4 years since you've done it, maybe you don't have the retention that you need to go out and practice on your own. So also, you certainly aren't ready to do complex fistula repair when you're after your PGY 2 year. So the staging of this and the timing helps with repetition and helps with appropriate learning for your skill set. Now, we actually have 3 match numbers. So if you're applying to Baylor surgery, you would put in however many numbers you want to apply for. And there is a dedicated match number for the global surgery program. You can match straight in. And this is really exciting. And I actually don't know of any other, please tell me if there is, of any other dedicated global surgery position in the match in the US. So this is something we're very proud of. In 2014, this was our first proposal for how we wanted to structure the program. And you can see it incorporated a number of specialties and elective time, as well as on Wednesdays, we wanted to include didactic time for training in things that were not necessarily skills-based, and journal clubs and whatnot. Then as time went on, we continued to modify what we wanted. And you can see, I think GS2 ended up with a little bit more elective time and not as much subspecialty time. Also included an option for tropical medicine learning. You can do an additional year with an MPH. So we made it a little bit more flexible. Also advocacy, if you would like to work at WHO, you can do that. This, I think, is really interesting because right now in our program, we have 3 global surgery trainees, 1 at each year. And you can see that this is actually very flexible. So this is the 3 separate proposals by each of those residents, and they each reflect their specific interests. So I'll go back to it. I know that's a lot of text, but you can see these three people. You've been hearing from Dr. Megan Vu and Dr. Yumna Sharif today, and I am really excited about them, but they also have very specific educational goals that are not the same as each other, and they're not the same as my goals. So Megan Vu is a lieutenant in the Navy. She has particular interest in orthopedics. She has more time in her schedule for orthopedics, pediatric ortho, than I do. Yumna Sharif, she has a fascination with HCC. She is interested in becoming a congenital heart surgeon, so she has specific time for that. And it's meant to be flexible for the resident that's participating in the program. And then we get our next global surgery resident on match day, which I'm excited about. My particular training on my GS1 year included time in Malawi and Tanzania and Guatemala. This year, my GS2 year was a little bit more focused on advocacy and mobile surgery because it's an area of interest. You already heard about Centurandis. And Dr. Ray Price was kind enough to set me up with a rotation of Mongolia, which was really interesting. And I also got to learn about national surgical planning through that. And then I did some time at the WHO. We have a fantastic faculty. These are people that have dedicated a lot of their time toward building this program. You see, Dr. Rosengart is the chair. It would not exist as a program if he hadn't declared that it would be so. And Dr. Ollier is also, he's our program director and really fantastic. You heard about the work he's doing with Smile Train. If you're interested in numbers like I am, I have numbers here for you. If you want to know how much it costs and what your output is, I'm giving you all the data. So here, the first GS1 year, actually in just that 1 year alone, I did 400 cases and 100 ultrasound cases. Then, and primarily those were in rural rotations. Then the budget of that, so to go to Tanzania and Malawi and Guatemala and do rural rotations and burn away rotation, all of that came to about $10,000. It's actually much more affordable than you might think. Where do we get our funding? The first year was actually input by our department. So they decided that this was something worth investing in, and they did it. The second year, we had private grants for it. And now for the next 7 years, we actually have consistent funding through the Robinson Foundation. Another thing that I wanted to talk about was that training is not just for residents. To be practicing in a global surgery environment, you're going to be encountering things that you're not familiar with, and that applies to both residents and people who've been practicing in the U.S. for decades. So it's important to continue to get training. One thing that we have as an option for practicing surgeons is the Tropical Surgery, Obstetrics, and Gynecology CME conference. This is coming up in September, and because it's a skills course in the simulation lab, it's limited in terms of attendees, so only 25 spots. But you can find more information about the curriculum and how to register online. You can also see the program. This is our curriculum. There are actually two tracks. There's an OB-GYN track and there's a general surgery track. So if you're a practicing OB-GYN, you don't need to know how to do a hysterectomy. You can learn about emergency airway, things like that, chest tubes. If you're a practicing general surgeon, you know all about chest tubes. You can learn about hysterectomies, etc. And you can see a lot of these skills courses. These skills are useful for anyone, no matter what surgical specialty you're in. So there are two pathways. You can get a tropical surgery obstetric and gynecology certificate, or you can get a diploma. The certificate involves just taking that course. There's nothing else. And then passing the exam at the end. If you do that, you get a certificate. If you don't feel like taking the exam, you can still take the course and get 43 CME credits. Or you can be hardcore. You can decide this is really important to you, take the skills course, and then also take these National School of Tropical Medicine courses. And then at the end, then you're eligible to get not only a diploma in tropical surgery, obstetrics, and gynecology, but also a diploma in tropical medicine and sit for the CTROP Med exam. But the takeaways I want you guys to have from this are, if you're looking at your own institution, you're wondering how to build your own program, how do you start and what things you need to consider? So I think a good place is to consider what your goals are for your institution and what resources you have, and do it honestly. So if you are really strong in research, maybe research is the way to go. If you don't really have a lot of research, but you're more of a rural program, you have excellent skills training, maybe you want to focus that way. And see if you have resources in terms of funding and faculty to do these things. Also, what kind of educational type would you want to consider? So intermittent would be small, short-term courses, or maybe a month-long ACGME international elective, which is now an option for residency programs, or a rural elective. Now you can get your cases to count for your trainees, or maybe something larger that's incorporated into the structure of your residency program, like a fellowship, a research year, or time for people getting engaged. Then if you have even more resources and you want to have a long-term relationship with countries abroad, you can do a twinning program or develop capacity by building facilities and training programs such as Dr. Balford was talking about. One thing to consider is that when you are establishing these partners, you want to make sure that whatever you're developing is useful for both of you, and that you're both equally motivated and you're both going for the same goal, because having differences in relationships can really make this sort of development difficult. And you also want to be flexible and know that things come up, things change, and that's okay. And maybe it might end up with an even better product than you were expecting. But, you know, it's not the end of the world. Just keep going and reevaluate and make sure that your partnerships and your goals are really what you're aiming for. So it was very nice to meet you guys. You can contact me in a number of ways, and I would love to talk with you and answer any questions that you have. Thanks.
Thank you, Dr. Davis. Our next speaker is Dr. Abarbanell. Dr. Abarbanell is a congenital heart surgeon at the Washington University in St. Louis. In his fourth year of medical school, he worked at Carolyn Kempton Memorial Hospital in Togo, West Africa, on the general surgery team. He proceeded to train in general surgery in Indiana University, continuing to work overseas in Togo and Kenya. He completed an MS in clinical research and was the inaugural class of the Global Health Program. Please welcome Dr. Abarbanell.
Thanks, Megan. I appreciate it. Okay, well, I decided to come up here and be the only guy as an attending not to wear a jacket because I was coming from St. Louis and it was really cold this morning. So forgive me, I didn't wear a jacket. I thought about running out and getting one after seeing all my co-attendings wearing a jacket today. So I'll ask for a little grace on that matter. All right, so here I am, a congenital heart surgeon talking at a global health conference. And I will just tell you that pediatric neurosurgery says they're small with 200 people or so in North America. We are even smaller in congenital heart surgery. We probably have about 130 of us in all North America doing congenital heart surgery. So we are teeny, and it's almost like you know what everybody else is doing. And it's quite frightening. Some people have asked me, well, did you hear about Dr. Frazier? Yes, 2 weeks ago I heard about this. So it's a small world, and I'm sure that they probably think I'm on the lunatic fringe because here I am wanting to do something really off the bend. And so this is what I'm here to talk to you about. Is this the road less traveled if I pursue a passion for global cardiac surgery, in particular pediatric heart surgery? Let's talk about it. I had to use some speaker notes. I'm sorry, I was on a plane to Maine trying to get a heart lung, so I didn't quite finish my talk until about midnight last night. I have no financial disclosures. 2 objectives, really 3. One is not written. The first one is to talk about my experience as a medical student, a resident, and now a junior faculty. And when I say resident, that includes 7 years of general surgery at Indiana University, 3 years of adult cardiac surgery at Emory, and a year of congenital cardiac surgery at Children's Hospital of Los Angeles. So I did 11 years of PGY years. My wife did 6 before me, so we're a dual physician family. So that's 17 years straight of ACGME years we did to get to effectively my first job. Before this, I had 2 careers. I was a United States naval officer for 6 years. I went all around the world. And I worked in corporate America for years selling devices for Johnson & Johnson and decided I really don't like corporate America. This does not fulfill my internal drive to serve others. And I decided I would become a surgeon. Crazy, I agree. And then finally, I just want to, the second goal is to offer some insight in how to navigate a career in global surgery. And I will just caveat this with saying that I am not like some of the people in this room who have spoken today. I am at the very start of this, right? my first faculty job. So you got to take this with a grain of salt. I may come back here in 5 years and say that what I said 5 years ago was completely wrong. You never know. And then third, they're going to inject some humor here with some classic movie posters, which I think some people recognize, and maybe the younger folks in the room may be like, yeah, right, okay. So here I am, my mid-40s. Actually, I think I crossed 47 this year. I can't remember. Yeah, 47 this year, and starting a career in pediatric heart surgery. What am I going to do? When you start thinking about global heart surgery or global surgery in general, you might be like this picture. You recognize this as Julie Andrews in her prime, The Sound of Music with the Von Trapp family flying all over the hills of Austria. Life is wonderful. I mean, what could possibly be better, right? I was on a trip to Togo, West Africa. I ran trips as a medical student at the University of Michigan through the local CMDA chapter, taking the ENT faculty down there. So it wasn't a big thing to me. People were impressed, but the reality was I had a bunch of faculty that were looking for avenues to go overseas, and they just needed somebody to put together a team, take them to a safe environment. And that team went on for 8 years after I stepped down after 2 years of doing it. Sort of that getting out of the business model, which is great. So that was fun. I went to Togo, West Africa with what I consider one of my surgical mentors, who's Bob Cropsey, who Bruce will know from PACS. I enjoyed that, and that's really where I realized I couldn't do general surgery. And you might find that a little surprising because general surgery is definitely needed. I am a board certified general surgeon. But when I had a little neonate come into the ICU, blue, undiagnosed, no ultrasound to be able to figure out, and die from clearly a cardiac malformation, I knew I wanted to begin general heart surgery. Then I chose a residency that specifically had a global health track. So I went to Indiana University, and they had a tract out in Moi, which is the Moi Teaching Referral Hospital in Western Kenya. So I said, this is the place I want to come. At that time, I don't think Baylor even had a program. I don't even know if I interviewed at Baylor for surgery, but I interviewed for medical school for sure. They're one of the few programs that said, hey, as a third or fourth year general surgery resident, you can go out. So it's great. I want to come here. This is where I want to come. And during that time, I got my master's in clinical research, did all those things. I will talk a little bit more about my experience in Kenya in a minute. And then when I went to do my adult cardiac, I again sought a residency that would allow me to go overseas. Unfortunately, I was supposed to go to Enugu, Nigeria, and the funding for the program fell apart in my last year, so I actually was not able to go. I navigated all the things with the RRC and the ACGME to go out, but unfortunately it didn't work. In that time, though, while I was in the lab in general surgery, I still made sure I went out and did other things besides the Moi Teaching Referral Hospital. I went back to Tenwick, which is a faith-based hospital. I went back to Togo. And then you come to your first real stumbling block on the road, your first job. Because you have two choices, right? Are you going to do something in America and be a faculty on an academic university? Are you going to be private practice? Or are you going to go overseas long term, right? This is the question the folks who are starting residency and medical school you're going to face. And you have to make a decision. So why did I make a decision to go in academic surgery? I'll tell you, it's because right now I'm in such a conservative field of surgery, which is congenital heart surgery. We talked about how surgery is decades behind perhaps our medical colleagues. Congenital heart surgery is very conservative. I would not be able to sit for my boards. I would not be able to get a job in the US if I went overseas for my first job. That was made abundantly clear to me. And Dr. Osteen knows one of the orthopedic surgeons. He had to deal with this at Tenwick, and finally, years later, he's able to sit for his orthopedic board. So I said, well, all right, I'll get a job here in the US for a little bit, because congenital jobs, there is usually one open in the country a year. So I feel very fortunate to have gotten an excellent job. I said, all right, I'll settle at university, one that has a global health track and one that's willing to work with me. And this book here, I would highly recommend for folks to take a look at. I was able to download it, the PDF for free, and I don't know if it's because I had library access, so hopefully if you're here on the Baylor campus, you can download it, because I think, Dr. Price, you have written a chapter or two in this book. And I just want to, this is actually the core of my talk here. It's really 2 slides, and here they are. Here's the second piece, The Magnificent Seven. Most of you probably might know the newer version of this movie. This is the original version of The Magnificent Seven. This book, in my mind, talks about 7 important questions that I think are really the core of what I looked at, not having seen this book before I went out on my job interviews. And so I'd really like to focus on the 7 things from this book that I think are really important. And it's really just one section of this book. The rest of the book is excellent too, by the way. I just read it on the plane last night. So what is this Magnificent Seven? Well, it comes out of this one chapter where you got to ask yourself these 7 questions. So what ignites you? And so I figured I'll just tell you what ignites me, and then you can apply this to your own career. Okay, so for me, there's no doubt, like I told you, when I was in Togo, I could do a C-section as a 4th-year medical student. I had basically the gardener show me how to do a hernia and a C-section. No kidding, the gardener. I could do a laparotomy, but it didn't motivate me. It didn't, I knew I could say it was that kid that died, that baby. So that made me, that was my passion, right? That's what ignited me. So answer that question for yourself first. Number 1. Then you got to look at what are my strengths and limitations? Well, I thought my strengths were my prior careers. I've been in leadership, was in the Navy, managed a lot of money, managed material, managed tough situations. I was pretty tenacious in what I did. I loved what I did, actually. But I got out because my wife was a pediatrician and now a pediatric cardiologist. So she actually did her medical school and her training before I ever had any interest in medicine. Crazy story, I know. It's crazy, but true. So limitation was not my wife per se, but it's the fact that I was going to go into the field of surgery that was going to take me 15 years to finish once I started medical school. And I had a spouse who wanted a job. She was very interested in global surgery and, well, really global health in her perspective. So I had to make some decisions about that. And I had one influential mentor, which I think is important. It's on the next slide that we talk about this, but one mentor named Ed Beauvais at Michigan. And I said, Dr. Beauvais, I was 33 at the time. I was a 4th-year medical student. I was on his service in the Michigan ICU. And I said, I don't know if I should do this. I love this field, but by the time I finish, it's going to be 12 years from now. And he turned to me and said to me 2 very important things. He said, listen, every day of this journey that you spend with the patients is important. He said, the cream will always rise to the top. And that's all he said to me. So a lot of you have asked me today, well, what about X, Y, and Z? And I'll just provide you the same advice. Every day you spend with these patients is a tremendous blessing. And I've enjoyed all my general surgery time. I've enjoyed all my adult cardiac time and all my congenital time. I really, really have. Yesterday, I'll describe my day to you. I went to the hospital, did no cases, saw 2 consults, sat in 6 hours of meetings, went to the bedside to see a mother of a fetal patient I saw that had alveolar capillary dysplasia. Her infant died within 30 minutes of being born. We talked preoperatively about the potential for that. We sat and cried together. That was probably one of the best days of my life. Why? Because I saw that mom. I knew that mom. And I was there for her. That to me was what motivated me. Just like that case when I was back in a 4th-year medical school. And I love operating, don't get me wrong. I love operating. Taking the cross clamp off and seeing the heart start on the strawberry heart, it's pretty cool. All right, so what has already been done in the field? I had to do a lot of searching for this. In 2003, I started really entertaining the idea about doing cardiac surgery overseas when I was in medical school. I'll be honest, there weren't a lot of people that said it was possible. In fact, I think 99% of the time people said, there is no way it's going to happen. 3 minutes, yes, I'll be done. The reality is it wasn't true. People were already starting to consider doing this at Tenwick Hospital. People were already doing it from Boston Children's in Ghana. I mean, I had to dig through this to find this. And then when I was in the middle of general surgery, I found out that there's a program in Sudan run by Intel and an NGO named Emergency that is a state-of-the-art cardiac hospital that provides cardiac surgery services for free if you can get there. Tenwick Hospital has obviously taken off. So I realized that you do have to be a little patient and maybe a little persistent. Okay, so that's what's been done. How did I prepare? I'd read all the stuff on rheumatic heart disease because I knew rheumatic heart disease was a big killer. Millions of people in sub-Saharan Africa. I got my master's in clinical research. I did these trips like I told you about. And then, who does what I want to do? I contacted those surgeons and I said, hey, I'm interested in this. And I found 2 American surgeons who are congenital heart surgeons that do this full time. So I reached out to them and I talked to them and said, hey, what if I could work with you in the future? I started contacting them about 5 years ago, to be honest. Do I consider them mentors? Not quite yet. We're still figuring out our relationship. So you do need to find mentors. There's no doubt about it. And those mentors don't have to be in your field. They could be the people in this room that have experience in global surgery that can give you some guidance. Surgical societies, I think they're great. The ACS for sure, and the Society of Thoracic Surgeons for me personally, they constantly talk about how they want to go forward, but the reality is it's a little bit still in its infancy, I think. The ACS is certainly further ahead than the Society of Thoracic Surgeons, there's no doubt about it. We're going to get there, it takes time. All right, 5, how do I expand my network? How do I establish contact with people? Knock on doors, send emails, come to meetings like this actually. And that's how you cultivate these long-term relationships. So that surgeon I told you about that went with me to Togo from Michigan, I've kept in touch with him now for 15 years. His son is now in Burundi with a group, with one of my classmates who I introduced to my wife's, I introduced him to his wife, who is a mentee of my wife. So it's a small world, very small world. All right. How do I communicate my interests well? My elevator pitch speech, communicate your interests often. This is key. If you can answer question 1, you need to then be able in 1 minute, which I'm not going to give my speech now, Hafsa, because it's only 1 minute. You need to be able in 1 minute, be able to articulate what you want. Because when you go for your first job interview, they're going to ask you, and try not to fumble along like I'm sure I did at several of my fellowship interviews. Like, you want to do global health? Why is that? I'm sure I didn't have the smoothest answer, but after a few repetitions, I got it. Got a little squared away. Start writing. Brainstorm ideas. Write things up like, hey, what's the current status of cardiac surgery and rheumatic heart disease? Or pick a topic that's of interest to you in global surgery. Do a lit search. Start writing. Get your name out there. It will help you. Okay, it stimulates your minds. It opens up doors. It gets to people. All right, 2 slides left. The good, bad, and the ugly. This is the classic one. All right, why did I put this slide in here? Because the good is your enthusiasm. There's a growing groundswell of people here who are seeking to do things overseas. There's administrators, electricians, bioengineers, all across the discipline. It's not just medicine. That's the good. The bad? Well, there's continued unmet need for clinical care. Social justice has come up twice today. I really would, if I had more time, I'd talk about it. But reality is social justice is a huge key component here. And mentorship can be lacking in this field, no doubt about it. I mean, the only reason why I'm here is I interviewed a 4th-year medical student, Vivek, for WashU General Surgery, and he said, well, would you consider coming down and talking to us? Sure, I'd be happy to. Otherwise, I would have never known about this conference. What's the ugly? Well, you're going to encounter people who are going to have very definitive ideas about global health. I'll give you a few things that I've heard just the last week from a senior partner. So, no, you know, I really think your interest in global surgery is a weekend hobby. I don't think you can make an academic career out of it. Okay. I went in an interview back at one of my home institutions for fellowship, and they said, you know, they'd be better off in the mosquito nets and malaria treatment, not with cardiac surgery. I was like, wow, okay. I've even had people say, why don't you just volunteer downtown? They're homeless. I'm like, okay. You need to be able to answer those things in your mind. I'm not going to answer them for you, but you need to be answered them. How about this one? Oh, you need to focus on getting into residency. You need to focus on step 1, step 2. You got to make sure you get through your training. Okay, listen. Life, I agree, is lived in series, but you can pursue your passion too at the same time. Be smart. You're all smart. Here's another one. You work at a faith-based hospital, you will hear this. Oh, you're coercing people to believe the religion that you have at that hospital, to believe in Christianity, because you hit them at the most vulnerable time. You need to be able to answer that. All right, last slide. Here's the really final thing. Listen, if you want something that you've never had or never been done, you're going to have to do something that's never done too. Okay? That's my take-home message. It's been a pleasure to be here, and I really appreciate your time.
All right, thanks, Dr. Abarbanell. Next speaker is Dr. MacFadyen. Dr. MacFadyen is a clinical professor of surgery at the McGovern Medical School. In addition, Dr. MacFadyen has traveled to numerous developing countries teaching and performing surgery. In 1996, he helped to develop the Pan-African Academy of Christian Surgeons, also known as PACS, which trains general surgery residents in rural mission hospitals in Africa. PACS now has 70 general surgery residents and residency training programs in orthopedic surgery, head and neck surgery, cardiothoracic surgery, and pediatric surgery in 9 countries. Please welcome Dr. MacFadyen.
Well,
it's just great to be here and to see people that are really interested in global surgery, and I just would encourage you to do that. I'm just going to give you something from a personal standpoint and kind of a personal history for myself and for my family, because my family and I have done a lot of the global surgery as a family. And it's not been myself just going, it's been really myself, my wife, and my 4 children. And we've had a wonderful time doing that, and they're all very interested in global health. And that has been an exciting part for myself and for my family. So I titled this The MacFadyen Family on Call, because basically, if my children knew that there was an opportunity, they would be ready to go, even though they now have children. And it makes it more limited for their things to do, but they're looking forward to those opportunities. Just to ask a question here, really. How, where, and when can you serve? That's the real question. You can hear a lot of talks, you can hear a lot of opportunities, and you can get out there and you can look up all the journals and read up all on global health and all this sort of stuff. But when are you going? And are you really going to put your feet in the fire and go for it? And so that's the question that I would just ask. And I would say, too, that as you go, how are you going to serve? I think you need to learn. You need to contribute. You need to serve them. These people have real needs, and you need to meet those needs, and you need to go and serve them. So when we started, I didn't have any opportunities. I didn't think about much about global surgery when I initially started. I finished my residency in 1974. I was planning on academic surgery. I was already doing some research, very involved. I came here to Houston to be involved with some things with total parental nutrition. And in contrast to my previous speaker, who was interested in cardiac surgery, I was interested in cardiac surgery, saw the light in my first year, and got interested in gastrointestinal surgery and nutrition, and my whole career was changed. So I came here eventually. But we started looking for some opportunities after I finished my residency. About 2 years after my residency, we started looking at some things and found a mission group in San Antonio and started doing some short-term medical work into San Antonio, where we were going down and spending a week or two. And I took vacation time and saved up my vacation time doing different things on holidays, and would go usually on a 1 or 2 week trip into Mexico. We loved it. It was a great time for my family. And you can see my kids were involved with the things that they were doing there, got involved with the patients as they were waiting in line, often long lines, and they were very involved with those types of things. And we would go down by car, truck, or bus, whatever mode of transportation. But we enjoyed spending time with some of the people there, some of the missionaries, and we had a wonderful time of fellowship with them. And this was a picture taken in Swaziland, where we had the opportunity to work with another group over there, and did a lot of surgery and saw a lot of primitive surgery over there. A lot of things I was concerned about, certainly besides infectious disease, certainly issues related to HIV was becoming more of an issue and discussion point. And we were very concerned. While I was working, my children were doing different things, puppet shows and working and just playing sports with some of the locals. And they had a fun time doing that as well. But I began to see some other broader needs. And there was an article published about some of the needs about surgeons, how many surgeons were represented in different countries. You can see from some of these places that there's very few surgeons for the population. As was mentioned earlier, Malawi is certainly one of the poorest countries from the standpoint of surgical representation. And you look at those things, and I was just thinking, wow, great needs there. And I'm going to have to just get involved and do what I can. And I mentioned the thing about the CSRA in Atlanta. This was taken when I was on faculty in Georgia. And, but those numbers are really representative here in Houston as well. You know, one surgeon for 9,000 people. And you go to someplace like Malawi, there's one surgeon for maybe 1 billion. Man, quite a discrepancy, quite a need. Well, here's an operating room in Niger, out in the middle of nowhere, out in the desert. And there are great needs. This hospital is now one of our PACS hospitals, one of our training hospitals. And these surgeons are getting trained out there and meeting the needs. Basic requirements and basic equipment is there to do the work that can be done. It depends on the skill of the surgeon who is there. You also have to have a good anesthesiologist, and I will say that anesthesia needs are greater than the surgical needs. So the challenges are there. You need nurses. You need laboratory personnel. You need technicians. You need people to run the equipment that I'm using. And so those are the challenges. So if you think, well, you're not a surgeon, okay, fine, but there's so many other things that can be used as well. Hospital wards. Sometimes this is actually not a very crowded ward because sometimes the patients are under the bed as well as on top of the bed. And you just kind of work along and do what you have to do in order to manage their individual care. Available diagnostic tests are not always great, but I would emphasize for those that are in medical school right now, looking at what's important in your training, a history and physical is the most important thing that you're going to do. You know, right now there's a great deal of emphasis on just getting a CBC and a CAT scan. Many of the places we go don't have a CAT scan, can't even think about having a CAT scan. No one to support the CAT scan. Keep it running, have the money to build the building. But if you can do a good history and physical, can get a CBC, which you can in most places, maybe urinalysis, maybe electrolytes somewhere, you might have those advantages. But if you can get some of those things, you can do many, many things. Depends on the skill of the person who is out there. Get well trained. Certainly you can do diagnostic laparotomies. That may be your diagnostic tool. And you're going to hear a little bit about some of the work in Mongolia and the things that they're doing with laparoscopy. You know, they revolutionized some of the surgical care over there. Done a wonderful job with the things that they have available. Well, you know, I was at a continuing medical education conference. Christian Medical Dental Association puts that on every year. For medical missionaries. 1 year it's in Asia, next year it's in Africa. And this particular year, 1996, I heard this surgeon from southeast Gabon, way off, six-hour drive from Libreville, the capital, and he was saying, I can't do it anymore. I'm just overwhelmed. Single surgeon, got all these needs. What's going to happen when I leave? He said, I think we just need to train them. He presented that to a group of people who were there, other people like myself and interested in academic training. And we said, this makes sense. That's what we need to do. So the light bulb went on. And so we, at that time, began to form this organization called the Pan-African Academy of Christian Surgeons. And that was 20 years ago. And it has now grown. The person there on your left, David Thompson, is the one who was talking about this, and he's the one that brought up the idea and got it started in his hospital. And we're doing clinical training, clinical teaching, making rounds, just like we do here in the U.S. There's academic training, and as was mentioned earlier about this organization called CSSA, the College of Surgeons of East, Central, and Southern Africa, which has really had a very creative, very supportive role towards education and surgical management of patients in Africa, particularly on the east side, but they're now doing some things in Western African countries as well. And so we get our residents to pass their MCS exam at the end of 2 years and the fellowship exam at the end of 5 years. So that these guys can practice wherever they go throughout the parts of Africa. We also do training courses for them every 2 years. We usually do a basic science course for them. It's a 2-week course, and it's intensive. You thought your basic science and here in the U.S. medical school was pretty difficult. We really put it on them during that period of time. But they get a lot of things. Got not only lectures, they get hands-on things. We teach them how to suture, knot tie. We teach them some laparoscopy. We teach them how to intubate patients. These guys love it. And they really get in and they take this stuff and practice it and use it when they get home. These are our first 2 residents. One's now in Mozambique and the other one is in Madagascar. And they're doing a wonderful job. The one on the right particularly took a hospital in Madagascar that was really kind of going downhill and going to fall apart. And he was able to just really bring it back to life and make it a sustainable hospital, doing a lot of surgery there. One of our early graduates, Dr. Sanusi, is now head of one of our surgical programs there in Niger, doing a great job. And we're trying to incorporate more of our faculty, some of our graduates as faculty when they come back in. And we're doing that now. And we're excited about these guys as they come over and take over the things that are due. We want these guys, we want to train them, we want them to stay there, develop things in their own country, and grow the programs there under their leadership. Well, some of the things that are going on too, different programs that are out there, you can see those mentioned, as was just mentioned earlier about the cardiothoracic surgery program. And we're excited about those opportunities. And you say, well, why do you need cardiac surgery? Well, cardiac surgery is greatly needed. A lot of cardiac diseases are not really diagnosed, but then if they're diagnosed, how are they treated? But then also we have people who are available to train. And so that's where your expertise, as you develop that and use it, that's going to be very important. Oh, I forgot to really mention, these are the programs where they're located throughout Africa. And, we're trying to expand. And as we get personnel, money is available, but the most important need we have is really personnel. And that's why we need people who are really well trained. Well, just to tell you that by the end of 2018, we will have graduated 86 surgeons. The goal is to train 100 by the year 2020. We expect to be over that by the year 2020. The blue countries represent where our graduates are going now. They're all still in Africa, and we're encouraging them to develop more areas where they are working. So what are some opportunities for you? Short-term medical missions, you may only have a week or 2 available. Use what you have. Various hospitals. If you go to one hospital, I would encourage you to go back to that hospital and just keep going back, develop that relationship with them and find out what their needs are and expand on those things. It could be with a government hospital or an NGO type of place in Africa. Get involved in a training program. I think that really works extremely well. And certainly you can get involved with PACs. You can do teleconferencing, webinars, those types of things are available as well. There are other things that have been talked about here, Operation Giving Back. SAGES, an endoscopic society here in the U.S. is doing those types of things. Doctors Without Borders, Operation Smile, Smile Train, those types of things are available. So see what's out there, see what fits your needs. So here's the challenge. A professor in Harvard said, it's about people and skills. It's about systems and capacity. People and skills. Get well trained, use that skill, and go out and serve the people. So the question that I had initially is my question as I finish: how, where, and when can you serve? nice to talk about it. You know what they say in surgery, just do it. Get out there and do it. Thank you.
Thank you, Dr. MacFadyen. I'd like to invite Dr. Davis, Dr. MacFadyen, and Dr. Abarbanell back up to the front here, and we'll start our panel discussion. If anybody has a question, I'll bring the microphone to you guys.
Hello. So first of all, thanks a lot to all the speakers today and organizers and Rice for putting this together. Great day of presentations. So one thing common in all of the presentations, I've heard like a call to arms of the participation, and everyone kind of wants to find how they can participate. And so I just like to ask like any specific advice for not only the medical students, but I think we have business and finance and all sorts of students. So how can we kind of make that reality and really participate in one of these endeavors?
Well, I think you've heard several options. And Dr. Davis talked about working out and finding a residency that would meet some of those interests in global surgery. And I think that's a great opportunity. My track was different. And but in all these things that you're doing, find the specialty or the area that you want to be involved with and get well trained in that area. I think, as far as learning skill sets, ultrasound is extremely important. Durable equipment, very useful for most surgical issues that you're dealing with. So, get well trained and there are these global surgery or global health residencies, and that's what I would encourage you to get involved with if that's the way you want to pursue.
I completely agree with Dr. MacFadyen. I believe very strongly that you should find the thing that you are passionate about and that there's a way to work that into global health, rather than a lot of times people might encourage you to go into something that they believe sounds like it's very applicable to global health. And I don't think that that's the best plan. The best plan is whatever you're doing, you can make it useful. And whatever you're doing, be really fantastic at it. And if something doesn't exist, like congenital heart surgery is not huge globally, that doesn't mean you can't be a global congenital heart surgeon. So I completely agree. Do the thing that you love.
And I really have enjoyed the fact that I came from 2 other careers because it's given me a lot of insight. You could be a business person and help run the administration of that hospital. You could be an electrician and you could improve the electrical system in that hospital. You could be a computer person and you can improve the wireless. You can just hang a door straight with a level, which I cannot do, and fix the toilets. And that would be a huge benefit. I mean, it sounds crazy, right? You're like, no, listen, to make a hospital run requires a lot of people from a lot of fields. You can do anything. And as long as you're passionate and good at it, you will be an asset. I promise you. I know it sounds crazy. You could even be a cook. It would be great.
All right. Any other questions for our panel?
Yeah, so you mentioned that you've had some critique from colleagues about doing research in global surgery, and I actually had that from an advisor this week who said, it's interesting, it's great, but it's not academically rigorous. And I was wondering if you found a path, but I was wondering if you anticipate any changes. Medical students are changing, and there's a huge passion for global surgery right now among medical students. I was wondering if you've seen that as well within residency programs, and if you think this is something that's going to improve in coming years.
So I kind of glossed over my time at IU, but I would agree. When I started at Michigan in 2002, the global health program was really 3 people. Now, if you go to their website and you go to Global Reach of Michigan, you'll see they have like a 32-page document documenting where everybody's from and saying that they've had 50 papers published. So it does show you that times do change. At IU, which I was a little more familiar with because all that stuff after I left, we had the bioethics folks, the ID folks, I forgot who else was there, but they had F-32 grants, so 4D grants for bioethics. And as a surgeon, it's actually important, I think, to know bioethics. I took bioethics while I was there. There are lots of ways you can write a paper that's not surgical, but yet is fulfilling an academic niche. There's a guy at Boston, I think, who has $1 million grants, who's a surgeon for global health outcomes. So it can be done. The NIH gave $10 million for centers of excellence to 10 centers throughout the country. And Kenya happened to get the one for cardiovascular diseases. It's there. It's just people don't know about it. And we are definitely a niche field that is slowly growing. I wouldn't say slowly growing, but really exponentially growing. So you have to take it with a little grain of salt and then keep looking. That would be my advice.
Yeah, I think that that's really unfortunate that that's the opinion, but I agree that often that is the case, that people make that assumption. But I think hopefully after 2015, there have been some changes, particularly in global surgery with the Lancet Commission, with a lot of these publications that we've had that are not touchy-feely, they're very data-driven, and they're good science. And so I think that that's something that we can help change as a group, that we can focus on making this more, just making the research better, as long as we do that within a framework that is sometimes can be difficult in terms of ethics. We need to make sure that we're being responsible to any kind of host country, host institution. We need to not be stealing authorship. We need to be collaborative. So with those considerations, I think hard-hitting research is very important to this field. It's important to getting funding, and it's important for advocacy.
I would agree with all those comments. And it's really how you approach it, the quality of the paper that's presented. There's great interest in there for great papers to do, so I would encourage you to do it. World Journal of Surgery, for instance, has a very strong interest in world surgery, not only great stuff here in the US and Europe and, you know, the more developed areas, but, you know, has very strong interest in underserved areas. And so there are other journals, certainly the Lancet is a major journal looking at these types of things. But, you know, it's out there, it's for the taking. You know, you just get involved and do that sort of a thing and do it well. And they'll want to see this type of expertise.
All right, let's give another round of applause to